Good afternoon. So when I got asked to come and talk about shortage of GLP-1s, I thought, that's easy. I just swear for 5 minutes. Talk done. But that's how I felt at the beginning of the year when we started hearing rumors that there was going to be a problem. Now, there's complex reasons for it, and I could tell you all about the reasons, the greed of pharmaceutical companies and some of my fellow healthcare professionals, but there's no point. We are where we are, and we need to work out how we're going to deal with this. There is a national shortage of the vast majority of GLP-1 analogues. This isn't going to change any time in the near future. NHS England have said it'll be at least next summer before the situation changes significantly. And of course, this is a class of drugs that we use very frequently and are incredibly effective in people with type 2 diabetes. So, what do you do when confronted with a patient who says, I can't get hold of my GLP-1, went to the pharmacy, they don't have any? So, firstly, here are the do's and don'ts. Okay? Do only prescribe for the licensed indication. Okay? Makes sense, but actually you'd be surprised how many people will be, there will be a lot of people coming to you who don't qualify for GLP-1s. There's obviously a lot of press about the impact of GLP-1s for weight reduction and weight management. But currently, the national recommendations and the guidance is that we should not be using it for weight management. It is an agent that we use for improving glycemic control. So if you have a patient with type 2 diabetes who's got an HbA1c of 53, but has a BMI of 38, they do not qualify for a GLP-1 analog. Review the need for the therapy if not effective. Okay, we're really good, aren't we, as a group of clinicians, starting medications, but we often don't stop it when it stops working. And a large number of people out there who are on GLP-1s, either the GLP-1 never worked, or it stopped working, and they now need to be escalated to other therapies. So by doing some of these things, you preserve what stock there is for the people who genuinely need it. When you are talking about changing therapies, do use the principles of what we call shared decision making, and you guys understand that better than I do, so I'm not going to sit here and lecture you about what shared decision making is about, but you understand that. When you're thinking about alternative therapies, please think about also the weight reduction programs that we have in place, like the diabetes remission, which Annie, I think, is going to talk about next, or later on this afternoon. It is the remission program is an incredibly powerful way of improving diabetes control. Over 50% of patients who are going through it have gone into remission, and most of the others need an awful lot less therapy. Out of curiosity, how many people in this room have personally referred somebody to the remission program? Okay. I don't know what the current numbers are, but when I looked at the beginning of this year, across the whole of South Yorkshire, only 50% of GP practices had referred at least one patient to the remission program, which meant the other half had not referred a single patient. And yet these patients are sitting in every single one of your surgeries, coming to see you weekly. There are thousands of them out there who qualify. And the diabetes nurse are going to talk to you about the kinds of patients they want to see. But please, when you are managing these really complicated patients, we are here to help you to work through what alternative therapies there are, particularly the ones that may need to go into insulin. I know this is really hard, but the current national guidelines is we should not be starting new patients on GLP-1 analogs. That's a really hard thing for a clinician to be able to have to say to a group of patients. You can't have this because we don't have it. Okay? But we need to preserve the stock that we have for the patients who are currently on it, who are benefiting from it. Don't switch between preparations. Okay, so they come to you and say, I can't get hold of GLP analog 1. Don't just say, well, actually, let's try switching you, because as soon as you start switching, it causes problems with the supply chain for all the other GLP-1s. Don't double up on this. If you have the higher dose of a preparation isn't available, but the lower dose is, don't give them the lower dose and then double up. Again, that causes problems with supply for those who are on the lower dose. And most importantly, don't just stop treatment without thinking about, adding in alternatives, particularly for those who have higher HbA1cs. Just thought I'd remind you here, I did mention it, but what are the current guidelines about continuous GLP-1 analogs? This is what NICE recommends. They need to have lost 3% of their body weight and have a reduction in their HbA1c of 11 millimoles, 1%. They're not achieving that. The GLP-1 analog is probably not working effectively. There's always a temptation to go, well, you lost a little bit, let's just keep going for a bit longer. My experience is, and the evidence confirms this, is that if what they've done at 6 months is the best that they will achieve, and it's probably only going to get worse after that. So if they're not hitting these targets, the GLP-1 isn't working, and you need to think about alternatives. Okay? But don't stop it. Consider what the alternatives are. Initiate that either yourselves or refer them into the diabetes specialist team if appropriate. Now, you can all at the back read this, right? Great. So the Association of British Clinical Diabetologists and PCDS, the Primary Care Diabetes Society, have produced some joint guidelines. This is available on their website. This will be circulated to you. Don't try and read this. You can't. Okay, I'm just showing you what their guidelines are about how you choose alternatives. Just zoom into the first bit, which talks about, which is the pointer on this here. So if your prescribed GLP-1 is unavailable, or there's no beneficial metabolic response to the GLP-1, discuss with them, the individual, the need to consider alternative glucose-lowering therapy. If they agree, you go down this pathway, which I'll show you in a second. If they are reluctant to and remember we're talking about joint decision-making, then you do need to discuss with them the potential risks of intermittent GLP-1 supply. It's, they may not get it this month, but it might be available in a few weeks' time. And that may be better than them not being on it at all. But that's where that joint decision-making and that individualizing therapy comes in. But if it isn't working, or you decide that we are going to change it to alternative therapies, what should you be doing? Okay, my slide's changed again. Okay. If on insulin, optimize a regime, and you may need the help of the diabetes specialist nurses to do that. Okay. And then you've got different HbA1c ranges. So they've got very high HbA1cs. The likelihood is, they should have been picked up earlier, but you haven't. Doesn't matter. They're almost certainly going to need significant escalation of their therapy. These are the ones that are high risk. If you just stop their GLP-1 and then refer them into the DSNs, the likelihood is they could end up with a metabolic crisis. So please don't stop it until they've seen us. They may need, as a short-term gap, sulfonylureas but the vast majority of these are probably heading towards insulin. Okay? But as short-term rescue therapy, sulfonylureas can be very effective. If they have HbA1cs of sort of between 58 and 86, so moderately elevated, optimize current oral therapies and/or add in an additional agent is what the guidelines say. And of course, consider insulin. And again, these are the patients that the DSNs will want you to refer into them. If they've got a normal, well-controlled HbA1c below 58, again, the likelihood is that they may deteriorate when you stop their GLP-1. So you need to optimize the current oral therapies and not add in an additional agent. But probably in this group, because of the potential risk of hypos in a tightly controlled group, in people with tightly controlled diabetes, sulfonylureas are probably to be avoided. Not always, but probably. That's it. The DSNs are going to talk to you a little bit about their service and the kinds of patients that they want you to be referring into them. So I'll hand over to them now. Thank you.